Okay, so the question is, what is the utility of formal pneumonia scores in the emergency department to see who stays and goes, right? So I think that there is some use to CURB 65 and port scores to roughly put your patient in a category, but there is considerable patient variability even within those areas. Just because you're 65 doesn't tell you necessarily whether you're a super healthy 65 or a kind of sick 65, for example. So I think that it's a little bit too simplistic just to take a look at this big data of, oh, look, they took a few thousand people and they looked at who fit in this box and this group did that. I think that it's too blunt of a tool. That there are people that are going to be high on those scores that are safe to go home, that you talk to them, they want to go home, they look fantastic, and they have close follow-up, and it's reasonable. And I've sent people home that should have been admitted per CURB 65 or port score kind of things. I've also admitted people that those scores would have failed to pick up. I think that there is no substitute to the clinical gestalt of, does the patient look well? And I think that sometimes those scores are useful if you're way off the reservation and you're like, oh, they hit every one of the points of CURB 65. Well, yeah, you're going to admit them. But I think that there's a lot of variability.
I think they're great tools. When I'm on the fence, I'll pull them out and take a look at them. They were good studies, both of them, port and CURB 65. Just make sure that the patient that you have, before I say all this, clinical impression reigns supreme. If you feel the patient needs to be admitted, no matter what port or CURB 65 is saying, you ask that they come actually see the patient and put a consult in if they want the patient to go home. So have them, if you feel the patient needs to be there, put all this to the side. If you're going to actually use them, make sure the patient actually fits the cohort. All right. My example of this is a patient who had rib fractures post-trauma, and they kept throwing CURB 65 in my face. All right. This is a guy who came back like a week and a half, 2 weeks later. He had a pneumonia. They kept throwing CURB 65 in my face. It's like, well, did they study patients with rib fractures? No. All right. Well, then bring the patient in. He can't hardly breathe. Bring the guy in. So they brought him in, and they said CURB 65 score or whatever, mortality this, whatever it was. We're going to send him home. But 3 days later, he was still there. All right. The guy got worse before he got better. So make sure the patient fits the cohort.
Problem is that they'll typically look at one of I think it's the second cohort and port, and you end up having a 2% mortality, and they quote that as a reason to be able to send a patient home. And personally, I'd like to send more than 50 patients home with pneumonia before one of them dies. and so it's kind of a how you interpret your interpretation of what 2% mortality is. And if you look at the port scores, if they're going to send somebody home in that cohort, it needs to be somebody who has specifically good follow-up, primary care, has a good access, can get back in, and that's not our patient population. So they really don't. They're misinterpreting the guidelines when they recommend sending patients home that fall into these criteria.
And I think it's similar to the PERC score. Like if you're ordering a CTA on 20 patients a shift, you're ordering too many CTAs. But occasionally we've all seen that patient that's technically PERC negative, and we're really worried about them, and we get a CTA because we looked at the patient and we were worried for some reason. And you shouldn't do that every time, but big data is not going to remove you from the bedside. Like you can't over apply these tools.